So, extracardiac disease. We'll start with case 13. Mrs. Teeger is a 66-year-old female with a distant history of gallstone status post cholecystectomy and breast cancer status post radiation and mastectomy 1 year prior. She presents to the ER complaining of fatigue, weakness, and shortness of breath with pleuritic chest pain. The symptoms have been slow onset over the last month or so. On admission to the ER, temperature is 97, respiratory is 20, pulse 105, blood pressure 77 over 52. Oxygen saturation is 100%. She is alert and oriented times 3. Her head and neck exam shows a JV pressure of 16 centimeters. Her cardiovascular exam shows a distant heart sounds with regular tachycardia, normal S1, S2, no rubs, clicks, or murmurs. Lungs have 1+ crackles bilaterally and 1+ pitting edema. Upon inspiration, systolic blood pressure falls to 50 milligrams of mercury. Chest x-ray shows a mild to moderately enlarged heart. The ECG shows the following. Which of the following is the most likely diagnosis? A. Complete heart block. B. Pericarditis. C. Cardiac tamponade. D. Ventricular septal rupture. Or E. Pulmonary hypertension. And the answer is cardiac tamponade. So we see that the patient has a low voltage ECG, and in the question stem, we have Beck's triad. And Beck's triad is hypotension, distant heart sounds, and an elevated JV pressure. So when you have all these three things together, hypotension, distant heart sounds, elevated JV pressure, and then you see a low voltage ECG, then your thought should be that the patient may have cardiac tamponade. The other important thing is that we saw a pulsus paradoxus here, which is the finding that there is a greater than 10 millimeter drop in blood pressure with inspiration. And essentially, because there's an equalization of pressures between the left and right sides of the heart, because there's this hydraulic press upon the heart from the pericardial fluid, that it is actually much more difficult to get blood into the heart during inspiration. And so because of this, the blood pressure falls. So what is your next step to confirm diagnosis? A, a stress test. B, serum CBC and Chem7. C, a cardiac catheterization. D, echocardiogram. Or E, a nuclear scan. And the answer is echocardiogram. So an echocardiogram is easily obtained. It's something that's non-invasive and can be rapidly deployed to confirm your diagnosis of cardiac tamponade. So what's our treatment strategy of choice? Is it A, pericardiocentesis, B, cervicocentesis, C, cardiac catheterization, D, colchicine, or E, start chemotherapy for recurrent breast cancer? And the answer is A, pericardiocentesis. So the only way to really improve the situation is to get the fluid off the pericardial space and to relieve the hydraulic pressure upon the heart. And so a pericardiocentesis is where a needle is placed from the chest to the pericardial space to emergently drain the pericardium of fluid. So a pericardiocentesis resulted in drainage of 1.5 liters of bloody fluid, which was subsequently attributed to malignant effusion. The patient's blood pressure improved to 115 over 75, and tachycardia improved to 85 beats per minute, so essentially a normal rate. And the patient survived to undergo further consideration of cancer treatment options. So the key points in this case were that pericardial effusion and tamponade presents with shortness of breath, pleuritic chest pain, fatigue, and weakness. And this is more common in patients with trauma, infection, or cancer history. Beck's triad is hypotension, distant or muffled heart sounds, and an elevated JV pressure. The ECG signs of tamponade include a low voltage ECG, and sometimes you can get electrical alternans where the low voltage ECG alternates between, lower voltage on one beat followed by a higher voltage on the next beat, and so forth. Pulsus paradoxus is a drop in blood pressure of greater than 10 millimeters of mercury upon inspiration and can be seen in tamponade like in this case. Essentially, you want to confirm your diagnosis by rapid imaging, such as an echocardiogram, or if the patient has an indication for a CT scan, then that can also confirm the diagnosis. And then the treatment is emergent pericardiocentesis. Okay, now case 14. Mrs. Hodges is a 62-year-old female with a past medical history of hypertension, obesity, and diabetes. Current medications include lisinopril, injectable insulin, and hormone replacement therapy. She recently returned from a long trip to the Philippines to visit her grandson. During this trip, she had fractured her right great toe while running after her grandson, and she's rested her leg at the advice of her son, who is a physician. In clinic, she confides that she's been really short of breath over the last few days since returning from her trip. She has a dull substernal chest pain that is constant and does not radiate and has no aggravating or relieving factors. She also feels intermittently dizzy and says that her heart has been racing. On physical exam, temperature is 99, respiratory 22, pulse is 110, blood pressure is 110/70, and oxygen saturation 96%. She is mildly tachypnic and appears somewhat uncomfortable. The neck is supple and JV pressure is 8 centimeters. She has no bruise. Her heart has mild tachycardia at 110 beats a minute, and the tachycardia is regular. She has a slightly accentuated P2. No rubs, no murmurs. Abdomen is soft and non-tender. The right leg is slightly swollen above the knee, and the right great toe is tender to palpation. Clinic ECG shows the following. Which is the most likely diagnosis? Is it A, pulmonary embolism, B, pneumothorax, C, pneumonia, D, asthma, or E, pulmonary hypertension? And the answer is pulmonary embolism. So essentially, the patient has pulmonary embolism. So she has all three limbs of Virchow's triad, which is stasis of blood, vascular injury, and hypercoagulability. So all of these three factors contributed towards a blood clot which formed in her leg and then subsequently thrombosed and embolized to her lungs and essentially caused a pulmonary embolism. So which is your next best step in diagnosing the patient? Is it A, arterial blood gas, B, a chest x-ray, C, a CT pulmonary angiogram, D, MRI and MRA of the thorax and abdomen, or E, bronchial biopsy? And the answer is C, CT pulmonary angiogram. So the other choices are not quite as good. So arterial blood gas wouldn't really help you diagnose the patient. You could see a reduction in oxygen saturation as suggested by the SpO2 of 96%, but this isn't really a firm confirmatory test for pulmonary embolism. A chest x-ray won't really show an acute pulmonary embolism, and a bronchial biopsy won't either. The MRI or MRA of the thorax and abdomen may show the abnormality. It may show an occlusion in the pulmonary artery, but unfortunately this takes quite a bit of time for a patient to receive an MRI and MRA. And so a CT pulmonary angio is actually the best option because it can be performed rapidly and has the appropriate sensitivity and specificity to be able to rapidly diagnose the patient. So the key points here are that we need to suspect a pulmonary embolism in patients with thrombosis risk factors. We need to remember Virchow's triad of vascular injury, stasis, and hypercoagulability. And she satisfied all of these limbs of Virchow's triad because she had a fractured foot, so that contributes to vascular injury. She had a prolonged flight, which contributes to vascular stasis, and she was on hormone replacement therapy, and so that elevates her risks of hypercoagulability. ECG signs of PE can be pretty nonspecific. Usually tachycardia is the most common. Occasionally there's this S1, Q3, T3 sign that only really occurs in less than 50% of cases. But if you see this, this is suggestive of a pulmonary embolism and basically right-sided elevation in pressures. The diagnosis of a pulmonary embolism needs to be made rapidly, and a CT pulmonary angiogram is an excellent way to diagnose a pulmonary embolism. And the treatment is usually anticoagulants. In some severe or life-threatening cases, thrombolytics or catheterization can also be used as adjuncts.